allowing me to be here. And for those who don't know me, I am a neurosurgeon, and one of the areas of interest that I have is in pituitary surgery. And there are a group of 9 neurosurgeons in Halifax, and we all have some particular area of interest in terms of neurosurgery, and all of the pituitary surgery is done by me with the help of my ENT colleague, which many of you also know, Dr. Massoud. So what I wanted to do tonight is speak to you a little bit about what I call team tools and technology related to the surgery of acromegaly. I specifically have not brought to show any intraoperative videos, and I know that I'm happy to do that kind of thing, but I know that some people are not keen in seeing the real thing. But I have brought along a few props, and I hope that by the end of it you'll have a sense of how I look at things from a neurosurgical perspective. The other thing I should mention, if at any point during the presentation, please feel free to wave your hand or interrupt me and ask any questions. The other thing I should check, can you hear me okay at the back? Yeah, okay. I have no disclosures to make. That is to say that I have no financial gain by promoting any particular product or anything that I'm going to talk about. Not that I'm going to talk about any particular product. So what I would like to do is provide a little bit of different things, a little bit of history, and I think the history part is actually very interesting. It has a significant Canadian context, and I think that's important to understand. Also, from a historical point of view, you should know that transsphenoidal surgery and the treatment of acromegaly in particular has an important role in the history of neurosurgery itself, and we'll touch on that as we go through. A little bit of anatomy. Anatomy is really important in terms of treating someone from a surgical point of view. As many of you know, we go through a rather horrendous list of potential complications that can happen at the time of surgery, and the reason is because of the neuroanatomy around the area of the pituitary is quite complicated, and it's very important and relevant to understand that in relation to the surgery that's done. Technology continues to play an important role in various aspects of medicine, and in particular the development of certain technologies have been crucial in terms of the advancement of the treatment of patients with pituitary tumors and with acromegaly. And then briefly we'll talk about our experience, and I don't have to talk much about that because much of our experience is in the room here tonight. If we put up a list of symptoms and problems that patients have who have acromegaly, you folks will recognize many of these things on the list, and you will have various combinations of those as individuals. And as you know, the term acromegaly comes from the Greek akron for extremity and megal for great or enlarged. So enlarged extremities, in particular thinking of hands and feet, that is the derivation of the term acromegaly. What are we trying to achieve when we see someone in the clinic for the first time with acromegaly? What we're ultimately trying to do is normalize the growth hormone and the IGF-1 to control the morbidity or the bad things that can happen from having too much growth hormone, and also to bring the mortality rate, in other words, the death rate, down to where it should be when you compare that with others in the community. And we know that in long-standing untreated acromegaly, that the risk of death is higher, several times higher than it should be. In some cases, our focus is also on decreasing the size of the tumor itself, because the tumor can cause problems by producing excess amount of growth hormone, but it can also cause problems just by growing and pressing on structures that are around the normal pituitary. And so we are oftentimes wanting to decrease the size of the tumor and control the mass effect that it has, or pushing it has, on the tissues around it. And those particular tissues will become apparent when I show you some anatomy, but again, many of you will know that vision is an important one, and one that we pay a lot of attention to. And then ideally, if we were able to operate and accomplish these things, and at the same time preserve the normal functioning of the pituitary gland that's left, if we can find normal pituitary gland that's left, then that also would be an objective that we have. Again, these are objectives, and we obviously cannot achieve all of these objectives in everybody, but this is what we're trying to do. What treatment modalities do we have? We have surgery, medical therapy, and radiation therapy. And what I'm going to talk about is from the surgery point of view, but it is the first line of treatment in general with patients who have been diagnosed with acromegaly, but oftentimes it's a combination of these treatments that is necessary for any given individual. What are some of the factors associated with a good surgical outcome? In other words, trying to successfully achieve the goals that you have at the beginning. Experience of the neurosurgeon has been shown in numerous studies to have an important role to play in terms of outcome. And that makes sense in that if it is recognized that this is a relatively complicated procedure from a surgical point of view, and if you're only doing that every now and then it's hard to maintain those kind of skills. The size of the adenoma, and adenoma is just another name meaning tumor of the pituitary, so the size of the tumor is also important. A large tumor that spreads outside the area where the normal pituitary is can often get wrapped around various structures, and it becomes increasingly difficult to remove all of the tumor. And that some tumors have a degree of invasiveness, if you like, into the surrounding structures that makes it very difficult to remove from a surgical point of view. And as you might expect, the preoperative IGF-1 and growth hormone levels also do correlate with surgical outcome. And again, that makes sense because generally larger tumors will have higher levels of these hormones. As you all know, the pituitary gland, though very small, is very mighty. Small meaning the size of a small grape. And that size of a piece of tissue sits at the base of the brain, is connected to the brain, and it, through its interactions with the brain, control all the major hormones in the body. And the one that we're talking about tonight is growth hormone. And growth hormone, which is seen here, which is found in the pituitary, has, in terms of its secretion into the body, has an accelerator and a brake from the brain, from the part of the brain that's called the hypothalamus. And the accelerator, which says put out more growth hormone, is something called GHRH, or growth hormone releasing hormone. And the brake is called somatostatin. And so it is the balance of these two normally that controls your growth hormones and keeps them into balance. If you have a tumor that secretes growth hormone, the tumor grows and it does not have the normal responses that normal tissue would, and therefore the brake doesn't work anymore, and the tumor is producing excessive amounts of growth hormone. Where does the pituitary sit exactly? This is actually a section through a head, a human head, and this is where the pituitary is. And this is the brain over top, the skull and the scalp. And this is the brainstem that goes down into the spinal cord. Tongue here, nose here. And so this is where the pituitary gland is. And that's where the bone where the pituitary gland sits is called the sella turcica. And sella turcica means a Turkish saddle. And this is a Turkish saddle. And if you put that under there, you see that it forms a saddle like this, and in that saddle sits the normal pituitary gland. Now, if we look at pituitary tumors in general, we know that they're very common. Up to 20% of people will have a pituitary tumor. And as with many tumors, we don't really understand the basic causes of why people have these tumors. It's not something that you did, it's not something you ate, it's not because of, for example, smoking and lung cancer. There's a strong link. These happen for unknown reasons in the vast majority of cases. The pituitary tumors in general can be divided into two large groups. Those that produce hormones, and those are functioning adenomas or functioning pituitary tumors, and those that don't produce hormone. In other words, the tumor still grows, but it's not producing any excessive hormone. And those are non-functioning adenomas. So functioning refers to the whether the tumor actually produces hormone or not. And they're divided that way not only because of their biological behavior, but also they will present clinically in patients in different ways. And so non-functioning pituitary adenomas, these ones don't produce hormones, they continue to grow, and the most common presentation is loss of vision. And that's what we see here. This is the vision in the left and right eye as if you were looking out. If you looked out, the patient would tend to lose vision in the periphery of the left eye and in the periphery of the right eye. And that's what tends to happen over time. Functioning adenomas, the most common would be a prolactinoma, which is treated very successfully with medication. So it is very rare for me to have to operate on someone who has a prolactinoma. I think in the last 15 years I may have operated on less than half a dozen. And yet it's the most common pituitary tumor. And so the main tumors that we end up operating on in terms of pituitary are the non-functioning pituitary adenomas, the growth hormone producing tumors, which in children can produce gigantism, in adults produces acromegaly, and in patients that where too much ACTH or adrenocorticotropin hormone is produced, they have too much steroids, and that's called Cushing's disease.